If we have problems there, again, just wave at me. Okay? We had a bulb exposure here. The first thing that we need to provide is a proper isolation. And as I told you, this material is a really nice material and have multiple applications. And we will see here in what cases can we apply the next temp LC. It may be used for a complete isolation of the area. Can you turn on the sound, please, for the videos? We can use the material also for using it instead of the cotton pellet at the bottom of the endodontic access. We can use the material for protecting the pulp chamber when we need to proceed and do a pre-endodontic core build-up. It's really important to do pre-endodontic core build-ups, and this material will work for you as a guide for going inside of the pulp chamber and removing it in a really easy way. In a really easy way. So it has been demonstrated that the seal against bacteria is the most critical factor in endodontics, because our main problem are bacteria. We need to take out bacteria from inside of the root canal system, and we need also to keep away the bacteria that is in the oral cavity away from the root canal system. If you are removing caries, you have a pulp exposure, but you are not working under a complete isolation, you won't be able to apply a conservative procedure like direct pulp capping, because the bacteria will go inside of the pulp chamber and you will have contamination, and that treatment won't work. So since the point in which you decided to provide a proper isolation in the area, you will have multiple possibilities of treatment. Without that complete installation, you have just one way to go, and you have to follow that way. There are not so many possibilities there. So this is the case. We remove the caries. Here was the pulp exposure. We decided to cover that pulp exposure with MTA. Then we apply some glass ionomer for covering and protecting the MTA, and we proceed with the final restoration in the same appointment. And this is the final result. As you can see, the restoration is well adapted, even if it was really deep, almost reaching the bone. That was well adapted in the area, and the final restoration is acceptable. We follow the patient for 7 days. When you decided to perform a direct pulp capping, the patient may feel pain the next 2 days. Just a small discomfort in the area. But after 7 days, your patient should be totally asymptomatic. If the patient is still having symptoms, in most of the cases, you will need to proceed with the root canal treatment. But this topic of vital pulp therapy is really big. We can spend like 3 hours talking just about vital pulp therapy. This is just a small portion of this topic. So this was the clinical scenario. Basically, that moment we have one all restoration, one deep cavity, almost reaching the pulp tissue, and a caries below the all restoration. We proceed to remove it, and this was the final result. we place MTA for covering the exposure. We place la ionomer for protecting the MTA and for being able to proceed with our adhesive protocol for our final restoration. After 7 days, the patient was completely asymptomatic, and as you can see, we have the same problem in the first molar, really similar. The patient was asymptomatic. So we decided to proceed in the same way, and this is the follow-up radiograph after approximately 8 or 10 months. And what you need to check is an asymptomatic patient. We need to perform your sensibility test with cold. The tooth should respond normal to the sensibility tests. And after 6 months, approximately, you will be able to see a dentinal bridge in this area. And in this radiograph, it's possible to see a dentinal bridge that is started developing in this area. So the treatment is successful. This is the way in what we need to work. We need to work as a team, always. Who's the people in the team? You, as a clinician, your dental assistant, your patient, and your referral doctor. If you are going in the same way, you will be able to achieve the final goal and to have successful cases. If you decided not to work as a team and you decided not to go in the same way and fight your referral doctor always and fight your dental assistant always, the clinical practice is not going to be so successful. So it's really important to have that in mind. We have a lot of materials now. All of us, we are using resin and composite materials in our practice. And in this video, you are going to see in which steps of the endodontic therapy we may use them. In most of the cases, it's advisable that if after removing all restoration, after removing caries, you lost one of the walls of the tooth, you will need to rebuild that wall. Because we need to have a pulp chamber surrounded by walls for having and keeping the root canal irrigant inside. In that way, you will be able to deliver the root canal irrigant all along the working length. And for using these materials, there are different scenarios for applying them. The name of this particular material is Easy Fill, and we can use it as a pre and post endodontic core build-up. This is after the endodontic core build-up. We can use these materials for a deep margin elevation, like in the case we already see. Even if the caries of the affected area is too deep and almost reaching bone, you will be able to achieve a proper rebuild of that wall. And proceed in the same appointment with the final restoration is possible. Sometimes we remove caries, we do not reach the pulp tissue, and what we need to do then is just to proceed with the restoration, with the fill, with the material of your choice. Nowadays the amalgam is not used a lot. We have changed to start using this kind of materials we can use these materials for final restoration after a direct pulp capping, as you already see. This is the case that I showed you at the beginning of the lecture. Those are really small pulpal exposures, and you have to pay a proper attention to the deep portion of your preparation for checking if you have a pulp exposure or if you do not have a pulp exposure in the area. But if we are not able to proceed in a conservative way, we need to move to the next step. And the next step is totally related to root canal treatments. We have seen diagnosis, we have seen complete isolation, we have seen final restorations, we have seen also direct pulp cappings, but now we are going to see what to do in the cases in which we need to do a root canal treatment. Look at this case. This patient have an old restoration with cavity below, caries below, with a base, with food inside, with some fractures. The previous treatment was a full pulpotomy. I don't like full pulpotomies because this can happen. When you proceed with a full pulpotomy, sometimes the root canal space can get contaminated, and when that space gets contaminated, the tooth will become necrotic. And sometimes, if the tooth do not become necrotic, you will have constricted canals, because the way of reaction of the pulpal tissue is always to produce dentin. The pulpal tissue can try to solve the problem in the area just forming dentin, so you can have constricted canals. So since the moment in which I see this case, I think this is gonna be a challenging case, because a full pulpotomy is there, I have constricted canals, I have a really destroyed structure in the area, and it was in that way. As you can see, there is no entrance. There is no visible entrance to the root canal system. The walls was really dim. We may have the risk of fracture, and in these cases, we need to take out from occlusion the teeth for decreasing the risk of that fracture. And what to do for trying to find these canals? What shall we do? We need to use magnification maybe. Maybe you decide to use EDTA or ELTA. Maybe you will decide to use ultrasonics for trying to remove tertiary dentin and for finding the entrances of that root canal system. And that was what we did. And after working with the microscope and with ultrasonics, we were able to find 3 entrances to the root canal system. We have one here, one here, one here. As it was a C-shaped canal, I decided to remove this bridge in the area, and this was the final scenario. And this was the final X-ray. We shape canals for being able to go inside and for having a proper space for delivering our irrigants in a proper way at the same time. That is the main objective. What we want is to deliver the irrigant all over that ramifications that we have inside of the root canal system. And for delivering that irrigant in an appropriate way, you may use ultrasonic devices, we may use sonic devices. You can manually activate your irrigant with the master comb, just moving the comb in and out inside of the root canal system. If you have a laser, you can use the laser also for activating the solution, but it's not advisable to work just with the syringe and the needle, because you can have successful treatments using the syringe and the needle, but there are some limitations, and we will see what limitations do we have. That device that you are seeing here, the name of the device is AQS, is a sonic activator, and this sonic activator has the characteristic of providing a multi-directional movement inside of the root canal with flexible tips, and that tips will activate and move the irrigant inside for trying to deliver the irrigant of your choice all along the working length, and for trying to push the irrigant solution in the ramifications, in the lateral canals, in the apical delta, in any extension of the root canal system. And because of the movement, it will create a vortex, this kind of vortex that will extend 2 or 3 millimeters beyond of the tip. So you may stay 4 millimeters less than the working length, and the device will transmit that energy. And we will see some clinical scenarios in which this device is working. The device is a multi-purpose device. It's not just for activating the irrigant. You can use the device for spreading the endodontic sealer inside of the root canal system. You can use the device for placing cements before the insertion of the master cone in the area. And you can use the device also for cleaning the pulp chamber, for removing the excess of sealer in the area, because as you know, sometimes it's hard to clean the pulp chamber. And it's really important to clean the pulp chamber for not having a color changing in the structure. This is a video in which you will be able to see how this system is working. The main goal is to enhance the action of our irrigants inside of the system. Because our shaping and our instrumentation is not enough. We always will have remaining debris, remaining bacteria in the area, and this active flow technology is the one that is going to help us every day in the clinical practice. So with this active flow technology, you will be more successful, and you have more chances of cleaning the system and going inside these lateral canals. The system is lightweight, is ergonomic. You can change the batteries really easy, and it comes with 3 sizes for the tips. One size is the 15 taper 2 for constricted canals. The second size is a 25 taper 2 also for using it in regular canals, and the other size is the 3502 for using it in big canals. This design of the tip is the one that will create the vortex, and that vortex will take out from inside of the canal the dentin and debris, the bacteria, the necrotic tissue or the vital tissue, and it's really easy to change the tips. You can change the tips in an easy way. In this slide, you are able to see the problem of the positive pressure technique. The positive pressure technique is the technique in which you are using just the syringe and the needle. 80% of us in the world, we are using a 27G needle for going inside. This canal in this premolar was already shaped, and the final shape was 3504. This was our final shape. It's a big final shape. And as you can see, the 27 needle is not able to reach the apical third. And your irrigant is going to reach just 1 millimeter below the tip of the needle. So our irrigant is going to be delivered just here. And what happened with this extra 4 millimeters? If you have bacteria there, the bacteria will stay there and you will have a failure. What happened with the 30G needle? The 30G needle is able to reach a proper length, and as you can see, if our irrigant will move 1 millimeter beyond the tip of the needle, you will reach a proper working length. The problem with the needle size 30 is that it's difficult to deliver the irrigant, and after doing root canal treatments, 3, 4, or 5 root canal treatments, at the end of the day, it's really tiring. You will finish the day with pain in your thumb, and that is not good for us. For avoiding these problems, we may decide to use any device for enhancing the action of the irrigant in our treatment. And it has been demonstrated that delivering the irrigant with a needle and a syringe is effective. You will have successful treatments. But when you compare that technique with the activation of the irrigant with any other device, the results are going to be in the side of the extra devices, because any device will increase the action of your irrigants. And if you have the opportunity to enhance and to increase the effectiveness of your irrigation protocol, you should do that, because the irrigation protocol is the most important part in the root canal treatment. You can have beautiful final obturations, but with beautiful final obturations, you may have failures because of a poor irrigation protocol. You may have ugly obturations, but if you perform an excellent irrigating protocol, you may have also successful cases. The final goal is to have beautiful final obturation, to have a beautiful shaping, and to have a really well-performed irrigation protocol. This device will help you in tissue dissolution, debris removal, and bacteria removal. In that 3 steps, the device will help to enhance the action of the irrigant solutions. And in this video, you will see a real clinical scenario in which the device is working. This is the main purpose, activation of the irrigant. And it's really powerful, as you can see. It will create that movement. You can use the device for delivering the root canal sealer and for spreading that root canal sealer inside of the canals with any obturation technique, with the technique of your choice. You can use the device for cleaning the pulp chamber, as you can see. You can activate the device has 2 speeds. The highest speed should be used for activating the irrigant, and the low speed should be used for spreading sealers, for spreading cements, for cleaning the pulp chamber at the same time, and it's really easy to get this result without working a lot with the cotton pellet trying to remove the debris from inside of the canal. Sometimes we are not able to finish our root canal treatments in one session, and we cannot let the patient go home without a material inside that will remain in the root canal system for killing bacteria and for working at the same time as a physical barrier. The material that we use the most is calcium hydroxide for an inter-appointment medication. You can use the regular calcium hydroxide, the powder, and mix the powder with anesthesia or saline solution. But this material, the menta paste, is a ready-to-use calcium hydroxide, but it also has barium sulfate. The barium sulfate will provide radio opacity to the material, and you will be able to see where the medication is located. Because if you place the material just in the coronal portion, it won't work well. If you place the material just in the coronal and middle there, it won't work well. You need to medicate the complete canal. And as you can see in this case, I decided to inject the material. If you want to inject the material, you have to use magnification. Otherwise, you can place the material with a master cone, with a paper point, for example. But in this case, in this radiograph number 2, this radiograph was taken just after placing the material inside of the canal. And as you can see, I extrude a lot of material. I was worried about the post-operative pain, but the patient didn't have any discomfort. And 7 days after, this radiograph was taken 7 days